sort of pathophysiology, and this is why it affects every organ in the body, because we have red cells sort of passing through every tissue. And as Kylie so beautifully told us this morning, it's more than just the red cell is the other thing about sickle cell. So it's white cells, platelets, cytokines. There's a whole sort of myriad of things that happen when there's sickle cells in the circulation at a high percentage that contribute to what we see in terms of end organ damage. We know that anemia is really important, and that's part of what we look for with screening, as well as hemolysis. I think we've got a talk coming up that will go very nicely in terms of many of these complications do relate to a lot of the hemolysis that we see with sickle cell disease. So that's a pretty long list, isn't it, of things that can happen when you have sickle cell, and the reason to put that list up is just to say that screening is not going to look at every single one of these complications, but really it needs to be a sort of top-down approach from head to toe to think about what might be going on. That's that slide, there we go. This slide really tells us that we see different complications in sickle cell at different ages. So in small children we have lots of pain predominantly, but problems with the spleen and infection. These are all the common things we see in little children. And then many of the other complications, particularly things like priapism and kidney issues, are really onset in middle to late age. And so this sort of knowledge of what is the natural history of sickle cell is also really important in terms of thinking about how we screen for complications. And we know that we have pretty good guidance in terms of how to look after sickle cell. We've had a great talk this morning from Dr. McCann about hydroxyurea. And I think the thing that's really changed in the last 2 or 3 years is there's international consensus now in terms of the therapies that we have and disease-modifying therapies, particularly hydroxyurea. The challenge we have here in Australia is we don't have access to all of these treatments, and so both screening and then what we go on to next, which is sort of curative therapies, really have a different importance when we're so limited in what we can do for treating sickle cell. So one of the comments I would just make about screening is that it's similar to what we're seeing in beta thalassemia. As treatment improves, many of our patients are certainly having much longer life expectancy. And so some of the problems we've heard about already this morning, such as leukemias and cancers, are certainly emerging in our populations. And perhaps, because patients are living well into middle age and beyond, we're now starting to see, the benefits of that, but also some of the complications. So just to very briefly think about why would we do a screening test and what does a screening test mean? And this is the sort of guidance from ASH in terms of what the expert panels use to put together their recommendations for screening. So to do a screening test, we need to make sure that the problem we're looking for is important. We need to make sure that the test we're going to do is acceptable to our patients, but it also has to be sensitive and specific. So it has to find a complication and have a sort of true positive or a true value. And then we need to think about cost, but we need to know that we're screening for things that we can treat. And I think this is one of the things that has changed in sickle cell in the last few years, is that previously we were screening for everything, and now as a sort of medical community we've stood back and said, well, we can screen for everything, but if we can't do anything about it, why are we putting patients through screening? I think that probably speaks to the conversation we started this morning about sickle cell tray, and I think it's really important to raise awareness about sickle cell tray. But I personally will take on board that I need to keep an open mind about sickle cell tray and what that means. But at the moment, without good evidence that we should be screening to that degree for sickle cell tray, I think there is danger in really setting up clinics for patients with sickle cell tray without knowing what we're going to do with that information and how we're going to help the person. And so that's that concept of screening. It's really important to think about doing this test, what does it tell me and what am I going to do about it? So this is similar to, as we just discussed, we need to have a test that's sensitive and specific, so finds the true positive, not the false positive. And then we need to know that we're going to have a treatment that really changes outcome. So I think one of the most important sort of screening concepts in sickle that's been present now for the last few years is thinking about cerebrovascular disease. And I think as clinicians, this is one of our most feared complications of sickle cell. it's one of the conditions where we know we've got excellent screening. So this is the study that was done in the late 1980s, I think now, that looked at children and tried to work out whether we could predict which children were more likely to get a stroke. So we know stroke can affect up to 10% of our population by the age of 20, and we know by doing a simple transcranial Doppler ultrasound and finding really fast blood flow to the brain, that predicts which children are more likely to get a stroke. And we've got an intervention. So we know that if we treat those patients who are identified at high risk with chronic blood transfusion, we reduce the risk of stroke by more than 80%. So this is a perfect screening test, okay? It's not 100% sort of true positive, there will be false positives, but there's obviously other tests we can do, such as MRI, to really help us work out whether it's true positive or not, but we have an intervention in the end. So this is the perfect example of a great screening test. And it's really sort of revolutionised or changed treatment and survival in sickle cell disease. So this is our group of patients who are identified by TCD, and that top group is the probability of remaining event-free, which is no stroke, in the children who are identified by the ultrasound as having a high risk of stroke who got blood transfusions. And the second group is the group who stopped transfusion. And so as you can see, about 55% of those patients who stopped transfusion then went on to have a stroke. So we know that this, chronic transfusion is the way to prevent CNS disease in sickle cell. So what's really changed in the last couple of years? So I don't think there'd be any disagreement from the audience about using TCD to screen for stroke, and we know it's a good test. What has changed in the last couple of years is that there's been a bit of dissent in population of doctors looking after patients with sickle cell in terms of who gets screened. So we know this screening is very good for SS patients with sickle SS or S beta naught. We're not sure about SC disease or S beta plus. But what we've come out and said in the last what the experts have come out and said in the last couple of years is in patients who have those compound states but have markers of hemolysis similar to patients with SS disease, that we should treat them the same as if they had SS. So what that tells us is that we think that the cause of stroke in sickle patients is this hemolysis that goes on sort of unencumbered. And so that's a really important change to screening for clinicians. So we know that really to offer a good service, we want to have transcranial Doppler available, and that's been one of our issues in Australia with smaller centres and smaller numbers of patients. How do we train people to do TCD well? And how do we make sure they're doing enough scans to be really good at it? We need neurologists and neuroradiologists who are going to help us look at pictures when we've got patients who are sick with sickle. And then this last point, there's a concept that we have a large number of patients with what we call silent brain ischemia who do need similar surveillance to our stroke patients. So this is a slightly frightening slide where we know that up to 40% of our patients with sickle cell will have some silent CNS damage by the time they finish high school, and that goes up to nearly 55% of our patients in adulthood. So this is this concept of silent ischemia. This is not picked up by our screening test, the TCD. We only find this on an MRI. So when we do an MRI, and that's one of the other changes to sickle cell screening in the last couple of years, is that in countries such as Australia, where we have very good medical care and resources, we should be doing an MRI around middle childhood. So children who can then have an MRI without a general anaesthetic should be screened to look for that problem that we know, which is silent ischemia. When we find silent ischemia, then we're having that difficult conversation about what do we do with this. I think the trajectory or the natural history of this is a little bit more challenging, but one option is to think about certainly hydroxyurea if these patients are not on it, but also think about chronic transfusion and treating them a bit like the patients with abnormal TCD. So really, to summarise neurological screening for sickle, we know we need to be able to do TCD. We also need to have good surveillance for children with learning disorders with sickle cell, and that really needs to start when they're very small, which is again why knowing when children are very little that they have sickle is really important. And then we need to use MRI in addition as another diagnostic test. I'll not talk you through that, that's just the complicated screening guideline. Okay, in terms of our next system, I'm going to briefly mention cardiopulmonary and kidney disease, and this was updated by ASH in 2019. And I think the really interesting thing here is we had lots of recommendations for screening, if I think back 5 years ago. And in fact, what we've done in the last 5 years is back off on all of that screening because of that problem where we knew we found changes on tests like echoes, but we didn't know what to do with that, or we found really high false positive rates. And then we were subjecting patients to invasive tests like cardiac catheter, which caused complications without being actually able to improve their outcomes from sickle cell disease. So what we know now is that it's difficult to know exactly what to do with patients with pulmonary hypertension. This is a really challenging problem. And that some of our screening tests need to be reserved for patients who have symptoms. And just in the interest of time, we'll very briefly go through these slides. But the reason we don't know what to do is we haven't had enough good studies where we've had head-to-head comparisons between people who have had echoes or test screening and those who haven't. We don't actually seem to have improved outcome for those patients. And the thing that we used to use to check for pulmonary hypertension, which is called the tricuspid regurgitant jet velocity, is not sensitive enough as a screening test. And so we were doing second rounds of tests and interventions on patients without necessarily having proven that they had pulmonary hypertension. So what's changed in screening is now a recommendation that we should take a really good history and examine our patients. It's a novel concept, isn't it? To actually really drill down on who has got an abnormality. I need to find out whether this person is short of breath at exercise, whether they've got a low oxygen sat when they're sitting in with me in the clinic or when they're sick, or whether they've got any chest pain. And these people are often sort of 20, so they should be able to get to the top of the stairs when they're at uni, going to their course. They should be able to play a game of basketball, and if they can't, that tells me that there's something going on. The other findings are going to be things that we find on examination. So what has now been recommended is to use other tests. So rather than just using an echo and that tricuspid regurgitant jet velocity, to also use a thing called the 6-minute walk test, which is literally where we put someone on a treadmill and make them walk for 6 minutes. We measure how far they go, we measure their saturations at the end, and we do a blood test called a BNP, which is a test that looks for sort of right heart straight. And so with that combination of tests, we can increase that sensitivity and specificity and really make sure that patients we're going to take to that next step, which is treatment or more invasive investigations such as a right heart catheter, that we've really spent a bit of time proving that this person needs this screening test. Similarly for pulmonary function tests, so this again was also in our long list of things that we used to order on many patients. Again, the recommendation is to not perform these tests routinely, and that's again because it wasn't really a good link between any of the things that you might be. If we found reduced lung function, it didn't necessarily correlate with increased pain or increased chest crisis or a decline in lung function. So then we have to say to ourselves, well, then why are we making everyone do this test? And what if we find something, put someone on treatment, but then we don't actually improve their outcome? So again, the recommendation is now to consider signs and symptoms that may help you work out which patients really need pulmonary function. And that's again things like chest pain, shortness of breath with exertion, the abnormal walk test, and a few other bits and pieces that might say, let's now go on and do a pulmonary function test. Again, for a sleep study, so sleep apnea is actually very common in our sickle cell patients for lots of reasons, but not every single patient needs a sleep study. And so again, taking that history, thinking about it's significantly linked often with things like enuresis or wetting the bed, but also school issues. So there's a number of things that might trigger you to do a sleep study, but it's not something we need to do in every single patient. So in summary, what we've done is wound back a whole lot of screening. It's not that common in medicine that things wind back, although I suppose that the story this tells is it's important that we go back and question what we've done for a long time because we're not necessarily always doing the right thing. Screening for renal disease, so this is a bit of a hot topic in sickle cell as well, and I think that's with recognition that a number of our adult patients have significant renal disease. About 25% of our patients will need what we call renal replacement, which is dialysis or kidney transplant as adults, and that's often something we haven't appreciated when they were children. There's good evidence and a recommendation that's actually now quite old from the NHLBI, which is a big US group from 2014, that mentioned screening for protein in urine from the age of 10. But in fact, there's probably evidence that we should start screening a little bit younger than that, and that's because we do think that starting hydroxyurea early, so remember I said you need to have an intervention if you find a positive, so if we get a positive then we can do something, and that's to talk to our patients about starting hydroxyurea, but also managing their blood pressure is important. So we've chatted a little bit about fertility and other issues today. I think this is a really important part of sickle cell care, and probably something that we haven't done well traditionally, but I think will continue to emerge as an issue for our patients. We know that young people may have pubertal delay, particularly if they've had significant chronic illness as a young person. We know that both females and males with sickle cell may have lower fertility, which can be for a number of reasons, but also probably the window in which a patient with sickle cell is fertile, so how the sort of fertility window is probably shorter, and we should be making sure we think about this and counsel patients if they're wanting to start a family, they think about doing that early. There's some controversies around the effects of hydroxyurea, and that continues to be, I think, a watch this space, and I suspect there'll be more evidence in the next few years. But then we have some of our curative therapies that are coming through, and again they affect fertility and infertility. So thinking all of this through and really having an approach to this from even when our patients are younger is important. Just related to hydroxyurea, so there has been concern. It's a bit like the story we heard this morning from Dr. McGann about hydroxyurea having a bad sort of name in terms of leukemia risk. Hydroxyurea has also had a bad name in terms of potentially reducing fertility for boys and girls with sickle cell. I think as we've gone back and asked that question, we've certainly a couple of papers in the last couple of years, both in males and females, that some of the lower fertility that we see, which may, it's likely in fact not to be related to the hydroxyurea, but is likely to be related to their sickle cell disease. But the good news from that point of view is in fact what we've found is by offering patients with lower fertility chronic transfusion, we do seem to be able to improve outcomes in terms of fertility both for females and males. So that's also a bit of a watch this space. Both those studies I showed were quite low numbers, so patients sort of 50 to 100 patients, so it needs a bit more work, but certainly the early signs are positive from that point of view. The reason that's important is if we have families where that's really the thing holding them back from starting hydroxyurea, if they're concerned about that, I think you can certainly say that the signs are reassuring that that is less likely to be such an issue. And just my last couple of slides relate to our patients with sickle who require chronic transfusion. So obviously we're weighing up side effects including iron overload, which is similarly seen in our patients with beta thalassemia. The comments I would make here are that the pattern of iron overload does vary depending on what your condition is that's requiring transfusion. So in our sickle cell patients, generally if they have significant iron overload, it usually affects the liver rather than the heart, but also the endocrine organs. And so that should come into play when we're thinking about how we screen for iron overload. So this is some of our general screening for iron overload, which includes measuring ferritin, but also doing some objective measurements such as MRI of the liver or cardiac MRI. And then thinking about endocrinopathies and endocrine organs, thinking about new testing for hepatic iron, so the FibroScan. There's emerging evidence that we can use non-invasive testing such as a FibroScan. And these are all important in terms of assessing for iron overload, but also monitoring our treatment. That might be my last slide, I think. Last slide? Oh no, sorry, thank you. So just putting all of that together, screening, how do we do screening well? So this is actually a map of all of the US Centres of Excellence in all the US Centres of Excellence for sickle cell care. And as you can see, they've got quite a few, so it seems a little bit unfair, but I suppose they've got more patients than us, so maybe that's why. We know that comprehensive care, which really incorporates much of that screening that I've mentioned, but also having specialists to help us manage patients with pulmonary hypertension or with liver disease or with whatever problem is thrown at us, that having a comprehensive care model is really important, and there's very good data that having comprehensive care really helps in terms of outcomes for patients. The challenge for us in Australia as the clinicians is setting up this model in your hospital. That continues to be a significant issue for us. but these are some of the benefits that are pretty well documented. I mean, this data is very old, but actually continues now in terms of reducing admissions, reducing unplanned admissions, and managing patients at home. So this is the hemoglobinopathy registry and some data that was actually presented at HSANZ last year. And so the reason I put that there is this is a comparison map to the one I just showed you in the US with all those centres. So, at that stage the registry had about 350 patients with sickle, which is about half of the total number of patients. These are the centres contributing to the registry, not necessarily all the centres that look after sickle cell. But what we need to do is we need to put a few more dots on this map, and then we need to turn this map into a comprehensive care map. This is just my last couple of slides to just really summarise. So we know vaccination is important. We've talked about renal screening, that I think really probably should start from early childhood. We know that pulmonary hypertension screening has got more complicated, and we really need to think about who we're screening. General blood pressure management is important. I didn't talk much about eye disease, mainly because there hasn't been much change to the recommendations in the last few years. Stroke, so I think that's pretty evident in terms of making sure we've got good quality screening for stroke is essential, and then thinking about reproduction and contraception. I think that, okay. Last slide. There are many things we don't know though, and this is just a couple of things I thought about. We don't know what to do about hips. So we have patients who have terrible AVN and hip disease, and there is no consensus about should we be screening for this. At the moment, we just mostly wait till they turn up with terrible hip disease, which I think is a terrible tragedy. But I also am not prepared to x-ray people multiple times when I don't know that I'm going to be able to fix it. And I think that cancer risk that's come up a couple of times today, it is certainly true that we are now seeing a significant signal of increased malignancy risk for our patients with sickle. Again, I think there will be more data on that in the next couple of years, but it's a challenging thing to manage currently because we don't really know whether there's subgroups of our patients, whether it's everyone, when to start, and we also don't know how to stop it, much like cancer for anyone. And I'm going to stop there.
Questions? All right, we have a couple.
Thank you, great talk. I was just interested in the CVS screening. Apologies if you said this and I missed it, but how long ago was the transcranial Doppler screening introduced?
Yeah, so the original study I think was in about 1980 something, it was in the 80s. So it's been around for a long time and sort of progressed a little bit, but again, even that's a bit challenging because ultrasound machines in 2021 are so much better than 1980, and so we often get stuck actually because we don't really know how to draw conclusions from that stage of what we do now, but it's been around for a long time.
Right, so there's no indication that that's able to sort of reduce the number of these silent infarctions that are coming?
Great question, yes. So no, they have gone back and I think looked at the original data set to see whether they could predict it, and it doesn't seem to be obvious from the transcranial Doppler. Yeah. You need an MRI, unfortunately. Yeah.
So Anthea, just with, so you put up the stuff that Adiola Kassim did with the rates of silent cerebral ischemia.
Yeah.
So it's just because I remember when this was presented at ASH, going to the talk probably 3 years ago.
Yeah.
They were talking that if you did a cerebral MRI scan at late adolescence, age 17 or early 20s.
Yep.
And you didn't see any silent cerebral ischemia, there was no point in doing further scanning because the likelihood was really, really low.
Yeah.
But that data that Adiola presented looks like you're still getting increasing numbers over time. So I wonder whether we should really be doing...
Yeah, I think it's a good question. So I suppose what we're saying is it's useful and reassuring to do an MR often in middle childhood just to see if they're going to be okay to go into high school and continue. And then I think the question in young adults in a resource-rich country like this is whether they get re-scanned.
I guess they were saying re-scan at like 17, 20.
Yeah.
If you haven't seen anything, you might likely to see something. But Adiola's data would suggest you can continue to see
Yeah, that's right. The line continues. Yeah, the line continues. So I suppose the problem is that whether we have the diagnostic sensitivity with an MR and whether a lot of that is actually sort of microvascular, although, I mean, it's silent infarction, so it's absence of any clinical findings of stroke, but then little patches particularly. I suspect the other thing that is probably, which I don't think is clear, but someone correct me if they've read anything on it, is what sort of MR do you do? Whether you do PET or SPECT, or what you find depending on what, how closely you look and what you look for. I think what we probably will know in the next few years then is in those patients who have silent ischemia that continues is what are we going to recommend? Because at the moment even the recommendation of what to do is sort of challenging. Yeah, I think you're right. I think it probably continues.
Well, anything our conflict we are resource rich.
Yeah.
So like at the outset we started doing it and then we stopped.
Yeah.
I think maybe we should
reconsider.
And I mean that was also after speaking with Michael before. I thought we should probably need to be doing it, but his own data.
Yes, would suggest that you do have patients who have a second event. And so then the question becomes how often, how often do we do it in adulthood? And we're going to have a group of patients who've even got silent ischemia, we're going to have a group of patients who've got florid vasculopathy, we're probably going to have a group in the middle. Yeah, I don't know how often, it's a good question.
So I guess I see a lot of patients with rare diseases, and this is probably rare in Australia, but internationally not. And so you've got standards of care and you've got guidelines. But my question is around equity of access to those standards of care for patients, particularly in regional and rural Australia.
Yes.
Because it's obviously a very complex screening process, and whether you've been thinking about that or any initiatives to try and improve access to that care or empower the local physicians, particularly with those questions that were raised this morning about transition.
Yes.
And so actually involving the primary care physicians as part of the conversation as well.
Yeah. Access to care in rural locations is so challenging. So we actually have a couple of patients that we manage from Melbourne who are in Katherine and Darwin. And some of that is because they met us in Melbourne and then the family moved. But you can imagine what that's like. Similarly in Tasmania, Tasmania has no capacity to look after sickle patients, and so we do that remotely from Melbourne. So it is a huge problem with equity. Even getting access to good quality TCD in the big centres in Australia is challenging because the numbers are small. I don't have a great solution other than workarounds, which is really unfair to patients, I think, other than utilising whatever setup you might have to get the patients down once a year to sort of do a comprehensive review and then send them back, and that model of liaising closely with the primary practitioner is sort of what we have to do. But that actual screening is hard. It's not really transferable to centres that are small, that don't have any expertise. So there is a huge inequity, absolutely. And I think there's a group of invested, keen clinicians who certainly will advocate and continue to do so. And I suspect things will change, but it's really hard. Yeah.
Thank you, Dr. Greenway.
Yes, thank you very much, Dr. Greenway. Really useful information. As I'm reflecting again as a mom of two young women growing up and trying to, in the transitions and all of these things you're talking about, I'm going, that's very interesting. That's something I didn't consider, something I wasn't aware of. So thank you everyone for the time and knowledge that you're sharing with us. We're now at the next session where we're going to look at blood transfusions in sickle cell disease. I have the pleasure of presenting to you Dr. Kobie von Wielligh and Dr. Jitan. They are transfusion medicine specialists working with lifeblood. So please join me in welcoming Dr. Tan and Dr. von Wielligh.
Thank you. So I'm Z, and I'm just going to do the first half of the talk, and then Kobie will take after following me. So transfusion in sickle cell disease. There we go. And before we start, I'd just like to acknowledge the traditional custodians of the land that we meet today and pay my respects to their elders, past, present, and emerging. So transfusion is an important form of management of sickle cell disease, and the principles of transfusions are to maintain or reduce the HBS percentage, and that in turn will reduce sickle cell disease related complications. Transfusions can be performed electively, as in the prophylactic setting, or during emergencies such as acute ischemic strokes or chest crises. And there's two types of transfusions, so simple top-up transfusions or exchange transfusions, which can be further subdivided into manual or automated transfusions. So manual exchange transfusions, I'm not sure if it's done very commonly these days, I would have thought not, but it involves venesection of the patient and then subsequent transfusion with cross-matched red cells. And automated transfusions, of course, requires the patient to be connected to an apheresis machine, and blood is then exchanged automatically. There are some advantages and disadvantages of these different types of transfusions. So simple top-up transfusions, of course, are easier to perform and more available in different centres. And exchange transfusions can lower the HBS percentage more optimally. However, is associated, or rather you would need specialised staff, specialised machines, and of course adequate vascular access. And we heard earlier about the issues of iron overload with simple top-up transfusions, and of course you will also get volume overload and increased viscosity as well, which is not great to have when a patient is already unwell. I won't spend too much time on the indications for transfusions, but we do have the prophylactic indications as well as the emergency indications. But what I will spend some time on is basically the selection of blood products. And I think there are three important factors to think about, which are antigen matching the red cells, followed by the age of the red cells, and lastly the conservation of cryopreserved or frozen red cells. And I'll touch on the first two, and Kobie will speak on the last one. So the first concept to really understand is the concept of red cell alloantibodies. So, and this remains the limiting factor in selecting adequate cross-matched red cells. So alloantibodies are antibodies which develop following exposure to a foreign red cell antigen, and an antigen is a protein or carbohydrate which sits on top of the surface of the red cell. And when the immune system recognizes a foreign antigen, it can form an antibody against it. It's kind of like immunization in a way. And what happens is that you can get alloantibodies, which can cause a lot of problems. One of the problems is it can be clinically significant and cause acute or delayed hemolytic transfusion reactions. And in a pregnant female, some of these antibodies can cross the placenta, causing hemolytic disease of the fetus and newborn. Now, another important point to note is that there's a lot of blood groups out there. So we are all familiar with the ABO blood group, so the O-POS, the A-neg blood groups. However, as of June of last year, the International Society of Blood Transfusion, the ISBT, has recognized about 345 blood group antigens. And of course, this number is increasing as we learn more about antigens and blood groups. So as you can imagine, there's a lot of blood groups to consider and to match. And it's very important to prevent alloimmunization, because the more antibodies a patient gets, the harder it is to provide adequate blood. And our patient population, the sickle cell disease population, have an inherent risk of increased alloimmunization anyway, and this is for two reasons. The first reason is the polymorphisms within the blood groups of the recipient and the donor. Although Australia is very multicultural these days. However, our donor population is still primarily comprised of donors from European heritage, whereas, of course, our sickle cell population, can be of African ethnicity, and the mismatch in inheritance of the blood groups, of course, can cause alloantibody formation. The other thing is that sickle cell disease itself is a pro-inflammatory condition, as we all probably know. And what this means is that alloantibodies are more likely to form at the baseline, you have, hemolysis going on at the baseline, as well as, minor vaso-occlusive events, and that increases inflammation. And during acute crises, such as pain crisis or chest syndrome, you do get an increase in inflammation and, of course, higher risk of alloimmunization. So what do our current guidelines say? So the Australian New Zealand Society of Blood Transfusion did publish this guideline a few years ago. It does not specifically mention patients with sickle cell disease, but it does consider this population under those who are chronically transfused. And they recommend, first of all, having a phenotype or genotype performed prior to their initial transfusion if possible. And of course, trying to match for an extended blood group. So your ABO and your rhesus, as well as your KEL, which is the big K over there. And preferably extending the phenotype matching to JKA, JKB, which stands for the KID blood group, the Duffy blood group, FYA and FYB, and big S and little s at the very minimum. Now, red cell phenotyping is another concept that I'm going to try and explain. Hopefully, people kind of get it. So, when we're trying to identify these different red cell antigens or blood groups, we do red cell phenotyping, and we do that in the laboratory. So what happens here is that on the left you can see a cartoon figure where we take the patient or a blood donor's red cells and we mix it with an anti-sera, which targets the appropriate antigen of interest. And what happens is that they bind together and they clump together, also known as agglutination. And on the macroscopic level, so at the level which we can see in the laboratory, you can see the blood cells clumping or agglutinating in the test tubes on your right. And that is considered a positive reaction. And hence the blood group is called present in this particular test sample. The Australian Red Cross Lifeblood provides red cells for the population here in Australia, and we are increasingly trying to phenotype our donors over the years. And as you can see, the last financial year that just gone by, we have almost got up to 30% of our donors are phenotyped, and this number is even higher in donors of blood group O. And this is good because we want to ensure that we can have a big donor pool so that we can provide adequate blood for your patients. And of course, once we phenotype the donors, we will actually publish the phenotype on the red cell label, as you can see in that circle on the right. However, phenotyping has its own limitations. Now, it is very time-consuming to perform phenotype for every single antigen that's available. And for some very rare blood groups as well, we may not even have the commercial anti-sera to actually perform phenotyping. And this is where genotyping comes in. So genotyping is done at the Brisbane laboratory here at Lifeblood. And what happens is that we are looking at the molecular basis of the patient or donor's blood so that we can sequence the DNA and then predict what sort of blood group they would express. Genotyping is especially important in patients or donors of African ethnicity because there is this reasonably common mutation called the getter silencing mutation, which means that on phenotyping, so on the serological testing, the patient may appear to be Duffy A and Duffy B negative, also known as the Duffy null phenotype. Now, this phenotype is exceedingly rare. But when someone has this getter silencing mutation, they actually have the Duffy B gene. It is just silenced on the surface of the red cells, but it's present in other cells. And hence, this is clinically important because we can then provide Duffy B positive blood to these patients, and there would be minimal issues with matching for Duffy B. And of course, it's all about increasing the donor pool. So the more negative antigens that you look for, the harder it is to find blood. So every single small antigen that we can not match for makes it much easier. Similar to phenotyping, we are continuing to genotype our donors at Lifeblood, and over the years, this number is increasing. And we have found a lot of rare donors with very rare blood groups, which we otherwise would not have found if we just phenotyped them. So genotyping is very important. And lastly, before I hand over to Kobie, I just want to briefly touch on red cell age. So the red cells that we provide from live blood can be used up to 42 days from donation, and they're stored refrigerated between 2 to 6 degrees. Refrigerated aged red cells has this concept of having this red cell storage lesion, which means that there could be multiple metabolic, biochemical, and structural alterations on the red cells. And sometimes this can be very similar to the pathophysiology of sickle cell disease. For example, sickle cells are less deformable to move into the vessels, and aged red cells, again, are also less deformable. And there is this theory that, using or transfusing aged red cells can exacerbate the symptoms. However, it's important to note that there's not a lot of really good studies looking into this area. Most of the studies, first of all, examine simple transfusions. And of course, the numbers can be very low, so we don't have a lot looking at exchange transfusions and the age of red cells. And this is reflected on our current guidelines. So the Australian New Zealand Society of Blood Transfusion guidelines do not have any specific recommendations on the age of red cells for sickle cell disease. And the American Society of Haematology likewise does not have any specific recommendations. And in Australia, based on our experience here, I think every laboratory or health service has their own policy as to how fresh they want the red cells to be. And whatever the policy is, I think one of the most important factors is actually matching for the antigen or the phenotype, as that is the most important thing. Is obviously we want to ensure that we prevent LMization. And I will end here and pass on to Kobie.
Thank you, Z. So we're going to look at a case study that we supplied blood for a patient, obviously. 35-year-old female with a known sickle cell disease came into one of the local hospitals. She moved to Australia 18 years ago and was known with sickle cell, but on no treatment, not on hydroxyurea, not on regular transfusions, and she had a recent spontaneous miscarriage and presented to the hospital with a hemoglobin of 57. I've indicated the normal range there, I'm sure you're all aware. She was A positive, and her phenotypes indicated there in the different colours. She, as Z alluded to, had a GATA mutation, so didn't need Duffy B neg blood, but serologically typed as Duffy A neg, B neg. I want to draw your attention that she was actually little s negative, but on transfusion, when she presented to the hospital, they only had S positive units. They matched for the other clinical significant blood groups, but gave her some S negative units. On genotyping, we confirmed what we already actually knew on phenotyping. She was E, big E neg, big K neg, FY A neg, JK A neg, and little s neg. And obviously, our genotyping do include hemoglobin S confirmation, and she was a SS. Now, how rare is this? How many units should we actually test to give 1 unit to this patient? With that phenotype, we have to check for 684 units before we can find 1 unit that would be compatible for this patient. So it is a rare group. And if we go to her blood groups, we can give obviously group A, and we can obviously give group O. But for both, even if we take both into account, it would still be a rare phenotype, less than 1 in 10,000. So very rare and difficult to match for us. Clinical history, she was discharged after 2 units, came back 10 days later with a hemoglobin of, I think, 67, initially, with bone pain, was diagnosed with avascular necrosis, and then they gave her another unit, again S-pos, and she dropped her hemoglobin to 46. And then when they retested her, she actually had another antibody, anti-S. She was also LEB negative, but because the Lewis B blood group system is usually not clinically significant, they decided that, and with advice that they could cross the Lewis B as long as the other significant blood group antibodies weren't crossed or was phenotype matched. and it should just be cross-match compatible at 37 degrees. But lo and behold, despite having more transfusions, with all the antibodies, all the antigens match, which you'll see later on, she developed antibodies to all of those. Her hemoglobin was still 52. And then they transfused again, and 3/4 way through the transfusion, she actually developed a transfusion reaction with fever and short of breath. And her blood pressure went up and her heart rate went up. No, I'm lying, her blood pressure went down, sorry. It's difficult, I can't see there, so I need to reach there, sorry. They did not provide the oxygen saturation, so we don't know, but she was admitted to ICU on that occasion, gave her oxygen, and she actually recovered spontaneously, but now her hemoglobin was 39 grams per litre. So what did they do next? So they did the usual transfusion workup, did the clerical checks, that was fine, did compatibility tests, they were all fine. Her bilirubin increased, her LDH increased, so it looked like a hemolysis. The clinical team at that hospital was unclear of the cause. They considered hemolysis, which could be there because she developed a new S antibody. They considered ongoing sickle cell crisis. They considered obviously hyperhemolysis. And then did she perhaps have occult bleeding because she just had a miscarriage? Was there retained products or anything else? But they started her on steroids, and they requested from us 6 or 7 units to do exchange transfusion. Now, I just showed you a few slides back how rare those units are. So how did we manage that? So then we contacted all the all of Lifeblood. We did a national search. We could find 3 units in Brisbane, 3 units in New South Wales, 1 unit in Victoria. And just want to give you a little bit of background on the logistics. Now, this was during COVID. There's no flights. We have to get these products again across borders, if you could call Australian borders, but interstate. We had to charter a plane for some of these because everything was closed down, can't get blood products. So it was quite a mission to get all these products into the correct hospital. Fortunately, we could do that. Her hemoglobin S improved significantly from 81 to 37%, and her hemoglobin unfortunately stayed in the 50s, but it's probably a little bit better than 39. Her bone pain improved slightly, but she was still on pain medication. And then the clinical team said, it worked well, we want to do another one in 2 days. And we said, yeah, sure. So we looked for more, and fortunately we did find more. So this patient was exchanged again, and she made a relatively good recovery to our knowledge. They didn't ask for more. So just a sort of a snapshot of what we do to get blood to you and how difficult it sometimes is. So how do we actually manage regularly transfused patients? It could be sickle or it could be thals, just as a general rule. So our regular exchange patients, once the hospital let us know that they have a patient that they want to exchange regularly and how many units they want, we actually create a file for them on our national blood management system, and we start collecting units. And as Z indicated, matching, phenotype match is more important than age. So we'll reserve those units for the patient. And then once the hospital puts in the blood net order and date of transfusion, we'll send the units over to them. Now, it is important to note that since leukodepletion, where we deplete our red cells from white cells, there's really a very limited need for washed cells. We will only supply washed red cells if a patient has recurrent transfusion reactions despite leukodepletion. So how do we manage rare blood groups or antibodies, just in general? So at Lifeblood, we find rare blood groups either in our donors or patient samples that get sent to us when someone has an antibody. Once we've identified that there is a rare blood group, if it's a donor, we'll send the donor a donor card and say, thank you for donating, you've got a very rare blood group. We would advise that you have some of your own blood stored in the system in case you need it at some stage. So we encourage autologous and homologous donations. Obviously that's not applicable to the sickle cell patients. They all have to undergo normal routine screening tests, and for our donors we want up-to-date information, especially contact information, because we may ask them to donate for a patient specifically. Then we also have an international database or rare database where we can get rare units. Now, if a hospital requires a very rare unit, there's some sickle cell patients in Australia that has one donor in the whole of Australia that can supply the patient's need. We will call in that donor because fresh is always best, so we would like a fresh unit to come in. It won't be for exchange, obviously it would just be a top-up if in case of an emergency. The other option we have is our frozen red cell infantry. Now we have a frozen red cell infantry. We freeze red cells by adding glycerol, and then they can be stored for a long period. We'll go through that in a moment. And that is for rare blood groups, rare or patients or people that have a lot of antibodies and you can't get all of those antibody mix for one patient. And we'll go through the timing of fresh versus frozen units, as well as the utility of thawed units and international searches. Oops, sorry, other way. Now, one of these international searches that you may be aware, in 2019 there was a little girl in the US called Zainab. She had a very rare blood group, India B blood group, and she had a cancer and needed a stem cell transplant, and they did an international call out for this little girl. So it was on social media, Facebook, everywhere, and all the donor services were contacted, blood services were contacted internationally to see if they can find donors for this little girl. And in Australia, we contributed. We had the fifth unit and we sent it over and she was transplanted successfully. So it just shows what international collaboration can actually do. So she actually recovered well. So cryopreserved or frozen red cells. We have an infantry, as I alluded to earlier. This is usually when the blood group is so rare that it's less than 1 in 1,000 or less than 0.1% of the population will freeze some of those cells. We prefer to freeze O cells if possible because, as you know, they're the universal donor. We can now preserve red cells for up to 30 years. Previously it was 10, but the new Council of Europe guidelines say up to 30. So we're very pleased with that. It's important to note there's a few really important things. Number one is a frozen cell, when we thaw deglycerolized it, it's really not the same increment as a fresh unit. So fresh is always the best unit to use. It takes time. It takes us at least 6 hours for one unit to be thawed and deglycerolized, and we need staff for that, and we have limited staff that's trained in this process because it's quite intensive. And so there's really very limited use in an emergency because it's going to take 6 or 8 hours for us to get you one unit that's not going to increment your hemoglobin by 10 most likely. So it's more like a top-up transfusion. And the expiry is very short. From the moment we start thawing, it's 24 hours and then the unit's expired. And obviously one of us must say it's fine to thaw the unit, and then you still have the transport time and transfusion time. So what can we all do with our sickle cell disease patients and rare blood group patients? Obviously this has been talked about today quite significantly, is testing. So we need to know if the patient has sickle cell trait. Sickle cell trait at this point in time can still not donate, obviously. So we're looking for the donors to be without sickle cell disease, sickle cell trait. They need to be ABO compatible with whoever they're donating for, if it's a directed donation, and we're looking for the rare blood groups. So testing. It would be nice if you could motivate your patients and their families to get tested. As we said, if you have 2 sickle cell trait patients, they have a 25% chance of one of the children not having any sickle cell. And if they then in that blood group category where they have a rare blood group, they may be the only donor for their family in Australia. So please take the opportunity to test the family. We often ask that family testing be done. And then if there's no sickle cell trait and they're compatible, obviously please encourage them to donate. And we just want to thank the organisers and then our lovely donors that come in and without any objections come in and donate. We'll call them and say, we have a rare patient, can you come in? And most of the time they would come in from wherever they are and donate. So they are just wonderful people, all the staff at Lifeblood. And then thank you for your attention.
Thank you, Dr. Von Wielligh. I'm sorry, I'm sure we were all dying to ask some questions, but just on account of time, we may not have to take questions at this stage. But thank you so much for your work. And on behalf of all the sickle cell patients who are blood transfusion dependent, we say thank you.
Do we know that we're ready to go? Yes, okay, great. So with great pleasure, I'd like to introduce Professor Greg Kato, who's the Executive Director and Global Product Lead at CSL and is affiliated with Johns Hopkins School of Medicine, as well as previously working at NIH and the University of Pittsburgh. And we're very grateful that he is here to talk about hemolysis and sickle cell disease. Thank you very much.
Thank you very much for this opportunity to present. I'll share my screen. It's okay. Okay, so I'm really pleased to have this opportunity to speak to you today about health complications of sickle cell disease and the role of hemolysis. Now, I may have misunderstood because I thought I was presenting at the patient symposium today. So this message is going to be pitched at a very focused layman's level, but we can also use this as an opportunity to get into some of the more fine scientific details for those of you in the audience that are interested in that. So here on the screen is Santonio T.J. Holmes. He lives with sickle cell disease. He's the son of an American football player, and his story is on our CSL Bearing Vita website, and I'll say more about that in a moment. These are my disclosures. I am an employee of CSL, and I'll tell you more about that in a moment. And this is just an obligatory legal notice. I'm going to give just a brief overview of the company, just so people can understand what CSL is and what we do. So CSL is a global biotechnology leader that develops innovative medicines that save lives, protect public health, and helps people with life-threatening medical conditions live full lives. We have over 30,000 employees and serving patients in over 100 countries. Our operations are located in 40 countries plus. I work for CSL Bearing, which is one of the 4 subsidiaries. CSL Plasma collects the plasma that we use to make our plasma-derived products. CSL Seqirus is our vaccine company, and CSL Vifor is a newly acquired subsidiary specializing in iron deficiency and nephrology. I work in King of Prussia, Pennsylvania in the United States, which is our national headquarters, but our international headquarters is in Melbourne, Australia. This is just a set of highlights of our research and development portfolio, but the reason I put it here is to emphasize In the first column in phase 1 here, we have hemopexin, which is being developed for sickle cell disease. CSL Behring's a values-driven company, and patient focus is our first and foremost value, but also innovation, integrity, collaboration, and superior performance. Okay, so on to the scientific topic, health complications in sickle cell disease. You got to hear quite a bit about the broad range of health complications in sickle cell disease, and I'm going to talk a little bit about how some of these complications develop in some patients and not others. Of course, sickle cell disease starts with the red blood cell and sickling, which all of you know a lot about. And these are some, but not all, of the many complications of sickle cell disease that can develop over a lifespan. Shown in the beige color are the acute complications that may bring patients to the attention of acute healthcare systems as medical emergencies. Shown in the light green are chronic complications that insidiously develop gradually over years, decades, and can lead to complications that can be health-limiting and indeed life-limiting. But it brings up the question, why do some people with sickle cell disease develop some of these complications while others develop other complications? Sometimes it's in the genes. It's very well known nowadays for many decades that co-inheritance of alpha thalassemia trait modifies the severity of hemoglobin SS sickle cell anemia. The anemia becomes milder and the frequency of some complications are reduced. Some patients inherit high fetal hemoglobin trait, and in this case also the anemia is milder and many complications are reduced. And as many people know, this high fetal hemoglobin trait is what inspired the development of hydroxyurea or hydroxycarbamide, the first approved drug for sickle cell disease. But another reason is the anemia in sickle cell anemia. And for the lay people out there, anemia means an abnormally low level of hemoglobin in the blood, and also means a low number of red blood cells. This happens in sickle cell disease because sickle cells break apart easily, which we call as hematologists hemolysis. And hemolysis happens faster than new red blood cells can be made to replace them, and the overall process makes sickle cell disease an example of hemolytic anemia. Just to think about this in terms of pictures, if we start with a red blood cell that becomes sickled, this red blood cell is rigid, and that impedes blood circulation. But besides being rigid, this red blood cell becomes markedly more fragile, and it can even break apart right in the blood circulation. And when it does, it releases free hemoglobin. Free hemoglobin, when it gets out of the red blood cell where it belongs, to outside the red blood cell in the plasma space where it doesn't belong, it can scavenge nitric oxide, leading to chronic endothelial dysfunction. It can promote the risk of developing pulmonary hypertension, and as well promote other chronic organ damage. When that hemoglobin becomes oxidized or becomes denatured in the circulation, it can readily release its heme, and the free heme is a source of intense oxidative stress. It acts as a pro-inflammatory molecule or danger-associated molecular pattern agent, and indeed free heme can promote vasoocclusion. The severity of hemolytic anemia is related to the risk of complications. Mildly low hemoglobin actually leads to a higher rate of pain crisis episodes. So what I mean is in the range of patients with low, mildly low anemia or severely low anemia. So mild anemia will lead to more frequent pain crisis episodes, more frequent acute chest syndrome, and a higher risk of avascular necrosis. At the other end of the scale, those patients who have particularly severely low hemoglobin levels are known to develop leg ulcers more frequently, to develop priapism in males more frequently, and to have a higher risk, lifetime risk of developing pulmonary hypertension. It's also associated with a higher risk of stroke and a higher risk of chronic kidney disease. Most patients are somewhere in between the extremes, but really this is a continuum of risk between mild anemia and severe anemia in terms of how it relates to the frequency of these health complications. And this isn't an all or nothing effect. This is really referring to a predisposition and just a tendency to have a higher or greater risk of these complications. During an acute pain crisis, hemolysis can flare up and hemoglobin can drop. But what I've been talking about up to this time is what the steady state hemoglobin level is in terms of its predictive value for risk of these complications. So just to get back to the free heme aspect of hemolysis, heme can make blood vessels adhesive. And in fact, this has been known for many decades. I'm showing you here a more recent representation published in 2018. These are endothelial blood vessel cells that are cultured in tissue culture. And you can see on the left side, these have been stained with a blue stain just to bring out the nucleus of the cell. Upon exposure to a low concentration, 20 micromolar or a higher concentration, 40 micromolar of free heme, you can see in the green staining of VCAM1 or vascular cell adhesion molecule 1, a very important adhesion molecule in cell-cell interactions in sickle cell disease. You can see in the lower row here, in pink staining for P-selectin, you see there's a little bit of P-selectin at baseline without heme, but as lower doses and higher doses of heme are added, you can see a very pronounced increase in P-selectin exposure on the outside of these endothelial blood vessel cells. And these are two cell adhesion molecules with now well-documented roles. And in fact, the role of P-selectin in sickle cell adhesion and adhesion of neutrophils, platelets, and other cells is exemplified by the benefits of crizanlizumab in inhibiting this. Over on the right here, you can see a similar story, except these are actually from intact blood vessels from sections from a sickle cell mouse published from John Belcher's lab. And again, over on the left, you can see stained in blue the nuclei of the blood vessel cells. But over on the right, after the sickle cell mice were injected with free heme, you can see green staining, and this green staining in this case is P-selectin. And so it's quite clear that P-selectin is activated in vivo in sickle cell mice, and actually other adhesion molecules are also activated in parallel. So this brings us to a story of what we call CSL 889 or hemopexin. What is hemopexin? Well, it's a naturally occurring protein in the blood. As we discussed, sickle red blood cells are fragile and they break apart easily or contribute to hemolysis. And hemopexin's job is to absorb that free heme as it's released in the bloodstream and to escort it to the liver where it can be safely detoxified and the iron recycled. And here's just a cartoon to help make this a little bit visual. A red blood cell, as it sickles, can break down, releasing free hemoglobin that free hemoglobin can denature, yielding free heme in the circulation. And hemopexin's job is to bind to that free heme and then transport it to the liver, where primarily hepatocytes through the CD91 receptor take up that hemopexin complex and break it down. When it does, it actually tends to consume the hemopexin protein along with the rest of the complex, and this ultimately leads to a circulating deficiency of hemopexin, and so there's less available binding capacity to absorb heme, and so free heme actually accumulates in the blood of patients with sickle cell disease. So in summary, the severity of hemolytic anemia can affect the risk of some complications in sickle cell disease, and hydroxycarbamide or hydroxyurea can reduce some of these risks, and other drugs are under study. Some other inherited genes also affect the risk of complications, some of them through the degree of hemolytic anemia that we've discussed, and some that actually act through different pathways that are independent of the anemia aspect. And CSL889 or hemopexin is a natural protective protein against heme that's now in clinical trial. For any patients who are viewing this presentation, I'd like to point out that we have other resources available on our CSL Behring website for sickle cell disease, and you can see the link here that yields that. We also had the opportunity within the last year to sponsor a special issue of the journal Nature Outlook on sickle cell disease. And these are actually magazine-style articles that are both accessible to the lay public, and it's also of interest to the average biomedical scientist or hematologist who's interested in sickle cell disease. And with that, I'll stop speaking and be happy to take any questions or have any other discussion.
Thank you, Dr. Gregory. Any questions in the room?
Thank you very much for that fantastic talk. I have a question about what other mechanisms we can use beyond hydroxyurea and chronic transfusion. We do seem to have a subset of patients who have very brisk hemolysis, and despite increasing hemoglobin to what we would think suppresses marrow, using maximum doses of hydroxy, they just continue to have bilirubins of more than 100, which I'm trying to think what that is in the US system. I just wonder if you have any advice, because I share concern about what that means for their vasculopathy.
Right, so in the US, there's an approved anti-sickling agent that's called voxelotor. I'm afraid I don't know if it's approved in Australia. It's just become approved in some areas of Europe. This is a small molecule agent that actually binds to the hemoglobin molecule and helps to stabilize it. It doesn't completely prevent the hemoglobin from sickling, but just mildly reduces the kinetics of sickling. This is enough to raise the hemoglobin level for a typical patient 1 to 2 grams per deciliter, or 10 to 20 grams per liter. This has been approved for the treatment of severe anemia in the U.S., and it's still an open question whether this actually reduces the long-term risks of the vasculopathy of sickle cell disease. But active clinical trials are underway by the company that manufactures it in order to get a better answer to this question.
Any other questions in the room?
It looks like Dr. Columba has a question.
Yes.
Oh, you're
Dr.
on mute,
Columba.
Dr.
Go
Columba.
ahead.
Thank you for this excellent talk. Is there more understanding on the mechanism of hyperemolysis syndrome and management on sickle cell children or patients, rather than just by standard mechanism. Is there more understanding?
Yeah, are you asking about hyperhemolysis?
Syndrome, yes.
Yeah, and you mean the transfusion-associated hyperhemolytic syndrome? Or
Yeah,
you just mean in general patients who have higher rates of hemolysis chronically?
No, transfusion-associated, related hyperemolysis syndrome.
Yeah, so a lot of the story that I was discussing today is has been investigated in the setting of chronic hemolysis. So what's the effect cumulatively of having more severe hemolysis than average for a sickle cell patient over decades of life? You know, for example, the development of pulmonary hypertension is typically more in middle age, around ages 30, 40 or so. It's even higher as age increases. And so this aspect is better understood. The effects of acute hemolysis and how much it contributes to vasculopathy is less well understood. But on the other hand, it does seem true that that some of the pathways that I've talked about, for example, the activation of cell adhesion molecules, that this actually occurs acutely. Well, it increases acutely when the hemolysis acutely increases, and this may be, this part I'm saying maybe because this part's speculative and it's hard to prove, but this may be related to what many of us hematologists know. This it's during a hyperhemolytic syndrome episode. Many of my patients have the most severe pain acutely that they've ever had. It's not always true, but it's occurred many times in my experience. That certainly the effects acutely of a sudden burden of free hemoglobin can raise the blood pressure. It can contribute to acute kidney injury, and it seems likely that it's contributing also to some of the other acute organ injury that can accompany an episode of hyperhemolytic syndrome. Does that answer your question?
Yeah, thank you. Because we had one patient who was quite challenging, and so far the theory beyond the hepatic bystander is just not very clear. I thought there's more studies and.
Yeah, so I'm talking about what pathophysiology may happen in that case, but in terms of clinical management, yeah, it's a very fine line to walk, because in such a setting, when a patient's had a reaction to blood transfusion due to known or sometimes undetectable alloimmunization, administering additional units of blood can sometimes feed the fire and trigger even further hyperhemolysis. And so, it's indeed a fine line to walk to try to treat the resulting anemia that can become quite remarkably severe at some times without aggravating the problem.
Okay. Thank you.
Thank you, Dr.
You're
Gregory.
quite welcome. Yeah, thanks again for the opportunity to speak.
Okay, well, thank you so much again, Dr. Gregory. That was very, very informative. I'm glad all these sessions, again, the sessions are recorded and they will be uploaded on our YouTube in about 4 to 6 weeks from now. So you can go back and relearn. At this point, I would like to introduce Dr. Anthea Greenway. She's a pediatric hematologist, Director of Clinical Hematology, Clinical Lead Apheresis, Clinical Lead Sickle Cell Disease at the Department of Clinical Hematology and Laboratory Services at the Royal Children's Hospital.
She's also my daughter's doctor for the past zillion years, and we call her the 7th member of our family. So welcome, Dr. Greenway.
We've run out of time. I know. Quick. Maybe I'll just ask for questions. No. Okay. I'm talking about curative therapies in sickle. Yeah, great. Okay. I'll try and speed it up. And I just wanted to acknowledge David Hughes, who's one of our BNT consultants at the Children's Hospital, who's certainly lent me some slides, which is great. I am looking at slides myself. Sorry, I'll get back on board. So this slide was just to remind everyone that there are lots of treatments for sickle cell that don't involve transplant. And I've put it at the bottom of the list, not because it's the least important, but I think all the things above are really important. The two things I was going to briefly mention are hepatic stem cell transplant, and so we know that this is a medical procedure to replace the bone marrow cells with healthy marrow from a donor. It involves giving chemotherapy and immunosuppression, but there's significant both short and long-term risks to consider. Then the second curative therapy is gene therapy in a patient with sickle cell. This is one of the first publications we saw for sickle cell back in 2017, so certainly on our current horizon. So in terms of outcomes for transplant, these continue to improve, and this is a big sort of collaborative study over several years, looking at over 1,000 patients post-bone marrow transplant, with 5 years survival in the 90 sort of percent. So that's a significant improvement from what we would have seen 5 or 10 years ago, but still significant risks. I think it would be fair to say that this is not a treatment that we enter into lightly for any of our patients and families. We know that recipient age, as well as how closely matched the patient and the recipient and the donor is really important in terms of predicting outcome. And certainly age sort of under 12 to 13 gives us the best chance of getting a good outcome, although there's not sort of hard and fast rules, and certainly making decisions on an individual basis is incredibly critical. Then thinking about how closely matched the donor and the recipient is also really important to try and predict how we can achieve this successfully. I think the things to say are that currently the most common indication for transplant is actually recurrent vaso-occlusive pain, which may surprise some in the audience. I think what is being increasingly shown with longer-term follow-up studies for transplant is that organ function does stabilise or improve post-transplant, and that many patients report improved quality of life post-transplant, but there are significant risks, and these relate to risks of subsequent malignancy, high risks of infertility, and the decision is particularly complex. Why is age so important? So this is related to the fact that for many of our patients, the number or the sort of end effect of that vasculopathy that is so well described really is accumulative over age. So when we do a transplant in a younger patient, they have had less sort of end organ damage related to their sickle cell. In our adult patients where the sickle has been present for longer, that is a significant concern. This also, though, provides us with the challenge of trying to predict very early on in a patient's life which patient may get the sort of most significant benefit from a transplant, and that's a really challenging question, I think, ethically. What we also know, and this is from the ASH guideline, which was released in 2020, I want to say, in relation to transplant, is that for our paediatric patients, so I've just told you that age is really important, but the problem is that the younger you do it, the more complicated it is, because small children have a really busy active bone marrow, and if we don't give really strong treatment, so really strong sort of chemotherapy and often total body irradiation, we find that there is a very high risk that they will lose the graft, so we don't actually achieve what we want, which is to cure their sickle cell. So that comes with its own inherent group of sort of problems. In our adult patients, there is good evidence that transplant that perhaps doesn't need such toxicity to get them ready may well be applicable. But then there's another group of complications for adult patients, because we know those patients have got more of the end organ damage because they've had their sickle for a longer period of time. So you can see the sort of push-pull decision that goes through, that we have to go through as clinicians in terms of working out which patients to put forward for transplant, or how we sort of have that discussion. So outcomes are very strongly affected by age of the patient, but also age of the donor is very relevant, disease status of the patient, but other things like nutrition and infection are very relevant for our patients. Some of the factors related to the donor include the HLA typing, so as I mentioned, the closer the HLA type, the better the outcome. Also, blood group matching is important, and CMV status is important as well. And then those extrinsic factors I mentioned, such as how strongly we need to get the patient ready for the transplant with things like the conditioning, chemotherapy and radiotherapy. Probably covered that. The only other comment to make, so remember I'm not a transplanter as I give you this talk, but the other comment to make is that things like the choice of what sort of stem cells we use for transplant is really important. So bone marrow harvest is one way that we can get cells to give back to a patient. We can use peripheral blood stem cells collected from a donor, but we can also use cord blood stem cells. And there's certainly risks and benefits for all three of those approaches, depending on the clinical scenario for the patient. When we don't have a really good HLA match, so sort of what we would call a 10 out of 10 match, what do we do? So certainly there's increasing interest globally in thinking about alternative stem cell sources for our patients with sickle cell disease. So that would be things like mismatched transplants, so from non-siblings, or what we call a haplo bone marrow transplant, which is often from a parent where there's a half match. Certainly you can see event-free survival for some of those alternatives, particularly haplo, have been not fantastic in previous years, but that is improving all the time. And so potentially some of these stem cell sources will become a reality. Certainly a number of multi-centre clinical trials at the moment looking at these options. When you have statistics like this, where we know patients will not do as well with something like a mismatched transplant, we then need to go back and look at the indication in the patient. And when we've got a really strong indication for a transplant, we sometimes then have to think about, you know, whether the sort of risk benefit is still in favour of proceeding with a transplant, even though we know that the outcomes may not be will certainly not be as good as that sort of 90 plus survival we saw for the well-matched sibling donor. These are the guidelines I referred to. So 2021, similar to the guidelines I showed you for screening. So this is a consensus-based document from multiple centres around the world to really try and help us with decision making about related to transplant. So what is sort of becoming apparent is that I think patients with most severe complications of sickle cell, patients who are really do not respond well to our current therapies, would certainly be something that we think about. We know that for patients, often acute chest crisis improves significantly post-transplant, and many patients do report improved quality of life, but pain unfortunately remains a feature. So many patients will go forward with their transplant but still have significant pain following the transplant. So from this guideline, what we know is that the recommendation currently is to really consider transplant for patients who do not respond or have inadequate response to standard of care. So I think the importance here is that I would really promote strongly that we have good engagement and good comprehensive care centres, so we're making sure that we've offered patients every single other option to have treatment for their sickle cell before we're getting to the point of thinking about a transplant. And that's because those risks I mentioned at the start, so the strong risk of infertility and the significant risk of malignancy, really have to be factored into that decision making. So it certainly is a choice and something we need to think about, but I don't have the sense that this is necessarily the way that we need to sort of treat every single patient. So this slide is probably a little bit old now, because really stem cell transplant, I think that is true, it is a one-time cure, so we're unlikely to go ahead and do multiple transplants, although that will occur in certain scenarios. But the other sort of curative treatment potentially that we're looking at now is gene therapy. So I think one area that really needs some consideration is for patients who have significant neurological disease, and this is in the setting that really, even with hydroxyurea and excellent transfusion therapy, we know a number of patients will continue to progress in terms of their neurological disease. And so for patients who've unfortunately had a significant stroke, I think scrutinising whether or not we can offer them a curative treatment such as transplant is important. So this is a study that looked at, so it's a multi-centre study from 7 centres that looked at 40 patients who were on a very good transfusion regime to try and prevent a second stroke. So these patients had all had stroke before. And what we found that is, despite ongoing transfusion, at least close to half of these patients went on to have further neurological injury after their stroke, despite the fact that they were transfused. And what that sort of really tells us is that these neurological complications of sickle are very severe, and this is one of the indications where strong consideration for transplant, I think, is needed. So again, this is this group that I mentioned in the previous talk, the silent ischemia group. So whether or not this group need to be strongly considered for transplant is an unknown at the moment. And I think thinking about those other options for treatment is important, but certainly I suspect in the next 5 to 10 years we'll have more data about whether transplant should be moved up that list I showed you at the start for this group of patients with silent ischemia. What we know about patients who have had a stroke or a neurological complication who go on to transplant, it does appear that the transplant does help to reduce the risk of further events. So when I told you before, sort of 45 to 50% will go on to have another stroke, but in patients who've had a transplant, there was still a small number of patients who had further events, but it was far less than the 45% in that other group. So it does seem that it does modify the outcome of treatment for patients with complications such as these. So I think we're now in a space where we need to think about transplant for all our patients and have a very open, honest sort of discussion. Depending on your setup and where you are, that will obviously involve clinicians who may be focused on sickle cell, focused on transplant. Some may do both, but I think it's important to have broad representation. There are significant long and short-term complications, so these really need to be factored in, and this is sort of a significant conversation that we need to have both amongst the treaters but also amongst the families and patients themselves. And I think shared decision making is really important, and making sure we're addressing concerns from patients and families is essential to get these sort of outcomes and the good sort of consent that we need to go ahead. So what's our approach at the Children's Hospital? So because we're a Children's Hospital, we have children with very busy bone marrows, and so that problem I mentioned where they have a high risk of rejecting the graft is a real consideration, and so we work very hard in the time before transplant to keep their sickle level low and their hemoglobin high and their bone marrow pretty quiet. We think very hard about some of that end organ damage that may affect our outcomes from transplant, so we think about their kidneys, we think about their blood pressure. Because of that sort of risk of sort of silent or other neurological disease, patients with sickle have a higher risk of some neurological problems, including seizures during a transplant, so we need to manage that actively. And we really think about all the different organs that we need to both screen before a transplant but also manage during the transplant so that we have a smooth and uncomplicated process as we can. We have pretty strict criteria for transfusion of both platelets and haemoglobin at the time, and we need to continue to monitor them neurologically. We need to think about the infection risk, which is one of the other big issues in transplant. And so we know that we're going to cause significantly increased risk of infection during and post a transplant, and then trying to revaccination, thinking about antibiotics and antivirals, all the things that we can do to reduce the risk of infection, both pre and post transplant, is really important. And then also thinking about our kidneys again, which often there's this sort of some silent kidney disease that needs to be factored in, and that affects both the drugs that we use but the surveillance and the close monitoring during the transplant. So we talked a little bit about this morning, but thinking about fertility options, thinking about how we get the patient ready for the transplant is important, and thinking about how we might mitigate or reduce those risks. And there's sort of significant science behind this that's evolving all the time, and again I suspect this will evolve over the next 5 to 10 years, but really trying to consider these options is important. So I'll just spend the last 1 minute on gene therapy. So this is that original, this is the results from the first patient that underwent gene therapy. It was reported back in 2017. And what you can see here is that the black line is actually a new hemoglobin. So the scientists or the clinicians put a gene into this patient's stem cells that allows them to produce a new hemoglobin called hemoglobin A. I've got my glasses on. And you can see that after these stem cells were transduced, this patient then produced about 50% sickle and about 48% of the new hemoglobin. And that was sufficient for this patient to do very well in terms of reduced sickle symptoms. So there's much activity in this space at the moment. This is a publication from Blood just last year, really looking at different strategies for how we address sickle cell with gene therapy. And in really simple terms, a couple of different models, one on the left and one on the right. On the left, we're putting a gene in, such as the example I gave you before, where we can make a new hemoglobin. On the right, we're using a different delivery system to clip or change that amino acid base pair that we know causes the problem with sickle cell. So there's lots of different strategies for sickle cell. This is just two, but this is gene addition on the left and gene editing on the right. And different ways to do this, using both things called viral vectors, where we use a virus to get the gene change into the cell, versus gene editing, which often uses the patient's own stem cells that are harvested a bit like a harvest and then have the new gene put in and then are given back to the patient, almost like what we call an autologous transplant. So sickle cell, as we've heard, is really a perfect disease for gene therapy because it's a single amino acid point change or a single gene change. Using gene therapy allows us to use the patient's own cells or the virus, so we don't have some of the problems we see with transplant, which include immunosuppression and GVHD. We're now out to quite a number of phase 3 studies, so that's exciting, and out to sort of 3 to 5 years for patients who've had this therapy. The problem we have at the moment is that we seem to have had, there seems to globally have been quite good success with reduction in sickle symptoms like vaso-occlusive crisis. But there haven't really been enough studies yet, I don't think, on what it's doing to end organ damage. And so whether we're actually shifting that vasculopathy and phenotype, it is hard to measure, I agree, but it is something that I think we really need to look at. One of the problems we've seen in this space is there certainly have been, unfortunately, a number of malignancies associated with gene therapy. And some of these relate to, again, the treatment before the gene therapy, but also what we call off-target effects. And so I think there is significant science behind this, but some challenges in terms of seeing how this is going to evolve over the next couple of years. Slide too much. That's just so early in the middle of the pandemic, actually, they stopped a number of the gene therapy trials because they were pretty concerned about outcomes for patients. Much of this has been overcome with new science, so there was significant concern in terms of linking a couple of cancers we saw in some of the earlier patients, but lots has been done by the companies involved and also the scientists to really scrutinise how that happened. They looked at things like that virus I mentioned and whether the virus was present in the leukemia, could that be driving the leukemia. They've done a good job of really disproving some of those theories. So I think that the trials are now continuing and back on. With certainly reported successes, so I think that I don't think that this sort of therapy has been eliminated, and I think it will be a future option for us, but there's still a lot of work to do. In my summary. So some of the challenges, this is my last slide, which just relates to what are the challenges in some of our curative therapies, and I think it certainly would be true to say, similar to our population, for the whole population, we are seeing the signal for some malignancy risk, and so thinking about how we really stratify and think about how we make a good sort of risk-based assessment of that is challenging. For our paediatric patients particularly, having to use the strong chemotherapy to wipe out the bone marrow is an ongoing challenge. The infertility remains a significant barrier for many families, where this may well mean that transplant is not an acceptable treatment option, and that's certainly a choice for many patients. Many of our families, as we know, will be limited because they don't have a sibling match, so we know that's that 21 in 4, sort of 25%, and that will be ongoing but potentially addressed by gene therapy. Really trying to limit end organ damage for all of our patients, whether they move forward to curative therapy or not, should still be our absolute goal, and I would completely echo Pat McGann to say there should not be a patient not on hydroxyurea, would be my summary. And I think just making sure we have good follow-up and set up to make sure that we're monitoring and looking after all of our patients, whether they move forward to curative therapies or not, is really a priority for your clinicians. I'm going to stop there. I think that's to
Thank you. Thank you, Dr. Greenway. We'll keep the questions for the panel discussion after the break.
Thanks, that was great, Anthea. I remember you said that, sickle cell was the diabetes of haematology. That's because it affects so many different organs, isn't it?
Correct.
And it's also the model system for molecular biology. You could teach all of molecular biology just by the globin, locus, and sickle cell. And the next speaker I'm going to introduce, Associate Professor Quinlan from University of New South Wales, has worked with me for many years on some of the fundamentals and of understanding the hemoglobin genes, which we believe will one day bring in the next sort of therapies which you were talking about just then. Over to you, Kate.
Thank you, Melvin, for the introduction, and also thank you very much for inviting me to be here today to speak. So I'm going to talk a bit about the work that our research group does in haemoglobin switching. So I'm going to start, and I'm from UNSW Sydney, as Melon said. Great. So I just wanted to start off with a who are we slide. So we're a group of basic scientists. So we're not medical doctors and we don't treat patients, but we're really interested in the science behind the globin gene locus and how that applies to patients with sickle cell disease. So we are experts in genetics, molecular biology, cell biology, and gene editing. And I think actually my talk's going to follow on really nicely from Anthea Greenway's talk, because it's talking about genome editing and how this can be used to understand hemoglobin switching and potentially in the future to treat sickle cell disease and other beta hemoglobinopathies. And this is our building here at UNSW Sydney, just showing where we're based. So as has been outlined in other talks, and I'm sure is not news to anybody here, sickle cell disease and other beta hemoglobinopathies are caused by mutations in the beta globin gene, which I've circled over there. And I'm going to show the different genes in this locus because that pertains to the topic that we're going to be talking about today. And sickle cell disease, as showed, is a disease that results from mutations within this gene. So one of the things we're really interested in our research is that we actually have backup genes. So I've circled here at the top the fetal hemoglobin genes. So there's this process called globin switching, and we actually undergo 2 globin switches in our lifetimes. So I'm going to explain. So firstly, you can see the embryonic globin, which is shown in orange. So the embryonic globin is expressed when you are an embryo. As we move through the development, so through the pregnancy, fetal hemoglobin is switched, fetal hemoglobin is expressed, which is shown in blue. And so there's a wave of fetal hemoglobin expression, which goes on till shortly after birth. Then after birth, the second globin switch occurs, and adult beta globin, which is shown in red, is expressed. And it's the adult beta globin gene that is affected by the mutations that cause sickle cell disease. So we actually have backup genes that are not expressed in adulthood, but that could offer solutions to sickle cell disease. So we and many other groups around the world are really interested in how we could reactivate the fetal hemoglobin genes in adults to treat diseases like sickle cell disease and beta thalassemia. So when I say in adults, I really just mean after birth, but it's because it's called the adult globin gene that we tend to say in adults, but it's really after birth when the fetal hemoglobin gene is normally switched off. So I've shown this in this graph by this spotty or dotted blue line continuing on. So instead of fetal hemoglobin being almost completely switched off after birth, it could be retained, and that we think and know from data I'm going to show you would be useful for patients with sickle cell disease and beta thalassemia. So we call this the reversal of globin switching. So instead of that switch occurring and the fetal hemoglobin going down, and the adult haemoglobin coming on, we would like to be able to reverse that switch. So we, as I mentioned, are not the only people in the world who care about this. So Merlin and I, and also a PhD student who works with us, went to the Globin switching meeting in Crete earlier on this year. There were more than 100 scientists there who were really, really passionately interested in trying to understand this switching process. And as Merlin indicated, this is a really fundamental genetic process, this switch between the fetal haemoglobin and the adult haemoglobin, through which a lot of what we understand about molecular biology has been discovered. So there's a wealth of knowledge here that we can draw on and apply. So we study in our lab a condition called hereditary persistence of fetal haemoglobin, or HPFH for short. And I know this is a really busy slide, but I'm going to break it down. So on the far right here, this shows a picture that we've seen earlier where fetal haemoglobin continues to be expressed into adulthood. And this is called hereditary persistence of fetal haemoglobin. Now, we talked about a bad mutation or a deleterious mutation today, which are the mutations that lead to sickle cell disease or beta thalassemia. However, the mutations that lead to hereditary persistence of fetal haemoglobin are good mutations. They're beneficial mutations because what they do is they cause this switch to be reversed. Now, these are very rare mutations, but in patients who co-inherit a hereditary persistence of fetal haemoglobin mutation, so a good mutation, along with a mutation that leads to sickle cell disease, they have greatly alleviated symptoms. So we know in patients that if we were able to reactivate fetal haemoglobin in people who had the sickle cell disease mutation, this would alleviate their symptoms. So these beneficial mutations fall into two categories. There are mutations that are small mutations. I'm trying to point with this, but it's not a pointer. So I'm just going to have to point with my fingers. So that there are mutations down the bottom here, which are single changes. So in individual bases of the DNA, and they lead to hereditary persistence of fetal haemoglobin, so really small changes. And there are also some really large changes shown in the top part. These are deletions. So where big pieces of the DNA have been removed in these patients, in these families. And we've been really interested in trying to understand these so that we can understand what's happening in hemoglobin switching and see how it could be reversed. So our aim, which I've sort of just said, but I'm going to say it again, is to study hemoglobin switching and the factors that control it to find new ways that we could therapeutically reverse it. Our approach. So in our laboratory, we want to model hereditary persistence of fetal haemoglobin mutations using genome editing, which Anthea has very nicely already introduced for me. We use CRISPR-Cas9 genome editing, which is a type of technology that we can use to make changes in the genome. We use base editing, which is an even newer technology that allows us to do similar types of things, so model mutations in the laboratory. And we want to use this to understand why these mutations drive fetal haemoglobin expression, why they cause this change, this reactivation of fetal haemoglobin in adult-like cells. So we're going to go a little bit more into the nitty-gritty here, but I'm not going to show too many results just because I want to illustrate the types of things that we're doing in our lab. So we study some proteins called transcription factors, and these are responsible for turning on or off gene expression. And as what we're trying to do here is turn on a gene, transcription factors are a really sensible place for us to start. So we wanted to understand how these particular mutations lead to fetal haemoglobin continuing to be expressed. So two very talented PhD students in our lab, former PhD students, Gabby and Becky, worked on some of these mutations, and we modelled these mutations in the lab using genome editing, and then used it to understand what's happening in people who have these mutations. And what they were able to show is that a number of the mutations change or prevent repressors, so transcription factors that turn off gene expression and that are responsible for fetal haemoglobin normally being off. These mutations stop those transcription factors binding, so they can't turn off fetal haemoglobin anymore, and fetal haemoglobin comes on. And we were able to identify the specific transcription factors that are responsible for that process. They also discovered that for a number of other mutations, these mutations, rather than stopping repressors from binding, made sites for activating transcription factors to bind. And these single base pair mutations, so single changes, were enough to cause a new transcription factor to bind to turn on fetal hemoglobin in cells where it would normally be turned off. We've also looked at the deletional HPFH mutations, so hereditary persistence of fetal hemoglobin caused by large deletions in the genome. And what we noticed, and this is work done by Sarah Topfer, who was also a PhD student in our group, what we noticed was that there was a common region. So when we lined up all the deletions, what we could see was that they centred around a region just upstream of the beta globin gene. So we wanted to focus on that part of the genome in detail and see whether that might be the reason why all these different deletions cause the upregulation of fetal hemoglobin. And to cut a very long story short, what we showed was that the adult hemoglobin promoter, so the top diagram is what happens normally. And in those cells, I haven't told you about the LCR, but there's this locus control region, or LCR, upstream in the locus, and this normally loops round to the different genes. So there's actually looping in the DNA, and it loops around to the different genes to cause some of them to be turned on or off. And what we found was that the deletional HPFH mutations prevented the LCR from looping to the adult globin gene, and instead it looped to the fetal globin genes. And what that told us is that we think the way these deletions work is by altering the looping, and this means that the fetal hemoglobin is turned on when these mutations are present. So that was a little bit hardcore science, so I'm going to take you back a step now into what this type of work could be used for. So we are, as said, not scientists, not medical doctors. We definitely are scientists. We are not medical doctors. And so, but other people are taking this type of technology into the clinic and using it in clinical trials. And interestingly, Beam Therapeutics, which is a company in the States, which was founded by David Liu, has a new clinical trial that's just started called Beam 101. And Beam 101 is a base editing therapy which is using one of the mutations which we have uncovered the mechanism behind, so one of the ones I showed you earlier, and that's now being taken into the clinic and being used for patients with sickle cell disease. But as I said, this is early clinical trials. So we are doing lots of work in this space, and we have current funding from the NHMRC, and we're looking at trying to find ways, not only using gene editing, but using other approaches that we could use to reactivate fetal hemoglobin in patients. We also recently were awarded a linkage grant from the Australian Research Council in collaboration with CSL. So these grants are linkages between industry and researchers. And this grant's really great because it's allowing us to explore improving gene therapy options or gene editing options for patients and looking at new targets that we could identify. So finally, I'd just like to acknowledge the team of people who we work with. So Sonia Guzzi is also a PhD student in the lab and is here in the audience, but she's not in this photo because it's too old. So thanks to COVID, we're a little behind on our photos and might have to improve that. But yes, thank you very much to the team. This is a team effort. And thank you very much for listening, and I've learned an awful lot today, and I'm really looking forward to answering any questions people might have now or in the break. Thank you.
We have time for one question. And then the rest can be in the break. One question.
So presumably if this works, there are a whole raft of genetic conditions where there are backup genes or there's genes that are potentially used at an earlier stage in fetal embryo development. So this has got potentially huge impact beyond sickle cell, hasn't it?
Exactly, yes. So this is, given that globin switching is so well understood, I mean, we're still learning a lot, but there's a really big sort of history of literature and knowledge in this space. I think this is very likely to be one of the first examples where this is used clinically, but as you say, there are many other diseases for which there is a gene that is expressed earlier in development which might be able to compensate for a defective gene which is expressed in adulthood. So yeah, absolutely. We're just starting here.
Great. Thank you, Dr. Kate.
Thank you.
Great. Okay, we are almost there, folks. Thank you for sticking with us. So we've been sitting for a while. Let's take a 10-minute break. There's afternoon tea outside.